Hi, good evening, dear colleagues. I'm Dr. Jihad, and our today's lecture is a continuation of what we have started, the series that we have started, What Surgeon Should Know. And it is about lower GI bleeding. And as a brief introduction, GI bleeding can be classified to upper and lower GI bleeding. And these are two different entities regarding the classic patient, regarding the presentation, the etiology, how to manage. So it's different. And if we are talking about lower GI bleeding per se, so it's defined as bleeding that is distal to the ligament of Treitz. And this is ligament of Treitz that we are talking about. It is originating from the right cross of the diaphragm and inserted in the duodenojejunal junction, the last part of the duodenum, the beginning of the jejunum. Any bleeding distal to that is a lower GI bleeding. And to have a common language that will help us in the next few minutes. So, normal fecal blood loss is about 1.2 milliliter per day. So this is not pathological. This is in a healthy patient. Normal to see such bleeding on laboratory study. If we are talking about acute lower GI bleeding, so that means sudden and hematoschisia, sudden onset of hematoschisia. And acute is about 20% of all the gastrointestinal bleeding. If we add the word colonic, acute colonic, so we mean that bleeding that is originating from either the colon, rectum, or anus. If we add the word massive, so that means it is above 1.5 liter per day. If we are talking about obscure GI bleeding, that means that there is a bleeding, but we didn't identify it on colonoscopy or upper endoscopy. There is a bleeding, there is a clinical or laboratory sign of bleeding, but it is not identified on endoscopy or colonoscopy. We will see in the next few slides that obscure bleeding, sometimes we call it suspected small bowel bleeding, and it have a special management and investigation protocol. Okay, if we are talking about overt GI bleeding, that means that there is a clinical presentation in a form of hematemesis, in a form of melena, in a form of hematoschisia. This is overt. If we are talking about occult GI bleeding, that means that there are no clinical, there is evidence of bleeding, but no clinical sign. So, how it will present? How it will present? It will present in a form of laboratory testing like iron deficiency anemia, or in the examination of the stool on stool analysis. It will tell us the laboratory finding will tell us that there is bleeding, but there are no clinical manifestations of bleeding. Okay, let's move to the incidence and epidemiology. And the lower GI bleeding is about 30% of all gastrointestinal bleeding, which means it is less common than the upper GI bleeding. And in general, Bleeding from the gastrointestinal tract is the most common cause of hospitalization among any other gastrointestinal diseases. And the number, if we are talking statically, so the number of lower GI bleeding is underestimated, and this is because some minor bleedings, like which can present like in the anal conditions or in a form of minor bleeding that is transient, this patient will not even present to the hospital. So the number is underestimated. And the overall mortality from the lower GI bleeding is about 2%, which is relatively low. And we will see why the mortality is low. Also, we have to recognize that about 15% of the patient that present or diagnosed as lower GI bleeding have source from the upper GI system. 15%. And this affects our management. Okay. The mortality related to the lower GI bleeding is not because that it is uncontrolled bleeding. No, about 80% of this bleeding will stop spontaneously. But the mortality is related to the patient comorbidities, and especially in the patient who present with lower GI bleeding. We'll see that these patients are classically elderly patient, multiple comorbidities on anticoagulation, have multiple comorbidities, as I said. So the mortality, they die, or the morbidity is not related to the bleeding itself. It's related to the condition that they have. Also, I have to add that the incidence of lower GI bleeding is increasing, and we will see why in a few minutes, in the few next minute. But I have to say that the incidence of, in contrast, the upper GI bleeding is decreasing. So the incidence of lower bleeding is increasing and the upper is decreasing. Okay. Here is an explanation of why there are increased of the lower GI bleeding, and this is maybe related to the aging of the population. We have the median age that is better than the past 50 years, and also the increasing in the usage of anticoagulation. Okay, let's move a little bit down. And here that they mentioned that an English study found that the median age is about, for lower GI bleeding, is about 74 years old, and they have usually a multiple comorbidities. And as we mentioned, that the incidence of upper GI is decreasing and the lower GI bleeding is increasing, and elderly have increased risk of both frequency and mortality from the lower GI bleeding. And there are also about 200-fold increased in the incidence of lower GI bleeding in the patient above the 80s compared to those in the 20s of their life. And this is maybe related to the main anatomical cause that causes lower GI bleeding. It is diverticulosis and angiodysplasia, and we will see how does diverticulosis present in more than 50% in the patients in the population who are above the 60s. Okay, this is one. Also, the increased usage of anticoagulation in the last decade, also, or the last 50 years, this also correlate with the increased incidence of lower GI bleeding. But even the incidence is increasing, the mortality and morbidity is decreasing. And we say that the morbidity and the mortality is about 2%, which is relatively low. And this is maybe due to the improvement of a procedure such as endoscope, upper endoscope, and lower endoscope. These were, and the presence of a trained gastroenterologist who can deal with it. So even the incidence is increased, the mortality is decreasing. Okay, and regarding the etiology, the causes of lower GI bleeding. And the etiology can be classified in a different ways, but we see here that here we classify it as a vascular cause of lower GI bleeding, and these include angiodysplasia, mesenteric artery ischemia, and colitis. Colitis, by the way, can be inflammatory, infective, or even vascular. And an inflammatory explanation or theory like ulcerative colitis, infective or amoebic colitis, and Crohn's disease, these can cause lower GI bleeding and related to inflammatory process, and neoplastic in a form of polyps, adenoma, or even carcinoma, and can present like a small bowel source like polyps, mecal diverticulum, which is originating from the ileum, and mesenteric ischemia, and this is a tumor, not timer, as I spell it incorrectly. Okay. Other causes we have to also to keep in mind the anorectal diseases and its different subtypes like fissure, hemorrhoid, and intussusception, which we can add it to the small bowel. Intussusception can present also like lower GI bleeding, and stercoral ulcer. And stercoral ulcer is a type of pressure, a type of pressure ulcer or necrosis ulcer. It's when the feces or the stool causes pressure on the wall of the colon and causes an ulcer and eventually invading the vessel and causes bleeding. And here is a photo, I found it, which is a little bit interesting. We can have a close look here. For example, from the causes of lower GI, first of all, here is the mecal diverticulum, which is from the ileum, intussusception, and carcinoma of the colon, which can be right or left. Classically teaching, we remember that on the right side it may present like iron deficiency anemia, on the left side it may present as bleeding, hematoschizia, and constipation. Also here we mentioned the small bowel tumor, which is rare but recognized cause of of lower GI bleeding. Angiodysplasia, and I want you to remember that angiodysplasia is more on the right side, small superior mesenteric artery embolism and thrombosis, either artery or vein, can be diseased and causes eventually ischemia of the bowel and bleeding. Also ischemic colitis, and when I want you to recognize the location, it's mostly in the watershed area, in the splenic flexure and the upper rectum. Also ulcerative colitis, diverticulum and diverticulosis, polyps, fissures, and we hear yes, the piles or the hemorrhoids. These are different causes of lower GI bleeding, and according to that we can recognize that the presentation will be different and the management will be interference. About the most common cause of lower GI bleeding. If we are talking about lower GI bleeding per se, it is diverticulosis, followed by the second common cause is anorectal diseases and ischemia. Less common causes include angioectasia or angiodysplasia, which we have already mentioned it before, that it is more common in the elderly patient. And on the right side, also less common causes is inflammatory bowel disease in a form of ulcerative or Crohn's disease, and neoplastic process in a form of malignancy. Rare causes of lower GI bleeding, and we should keep in mind it is polypectomy or post-polypectomy. After a colonic resection of polyps, we have to monitor the patient, and this highlight how important is the history from the patient, taking a proper history from the patient. Also radiation proctitis, which have absolutely different approach and management, and non-steroid anti-inflammatory drug induced ulceration, which is more prevalent in upper GI, but it's also an well-recognized cause of lower GI bleeding. Dual phi or dual foy lesion, I'm not sure about my pronouncement, but it is like an AV malformation. It is a rare cause, but it may cause massive bleeding, or usually it is a visible vessel. Typically no ulcer. The surrounding, this is the surrounding tissue is normal. The surrounding mucosa is normal, and regarding the histology, there will be solitary mucosal defect with erosion of an underlying large caliper tortuous submucosal artery. It's like a pinpoint defect that affect directly a large artery and causes bleeding. Yes, it is rare cause, but it may cause massive bleeding. Okay, if we want to talk more about diverticulosis as the most common cause of lower GI bleeding, and it's about 30% of the cases, and diverticulosis also can cause severe acute bleeding, as it's prevalent in the sigmoid, in the left side of the colon. And as I told you before, about 50%, half of the population that are above the 60s have diverticulosis. And bleeding among these can be up to 2%, the risk of bleeding up to 2% within 5 years, and up to 10% within 10 years. Okay, here I write some about the histopathology and how does diverticula develop. It's not in the scope of our lecture, but we can see how does diverticulosis present on colonoscopy. When we do colonoscopy, you see we as surgeons see the outer side of the bowel. This is how it's locked from the inner side. Okay. The second most common cause, as I mentioned, is the anorectal diseases, which can be present like hemorrhoid and fissure. These are the hemorrhoids. It's just a picture to increase our or develop our imagination. It's not the grade I want to say. I want you to remember this is how hemorrhoid, which can present like fresh red blood, or anal fissure, which also can present like with pain and bleeding. Here's a table that summarizes what we have already said about the etiology of the lower GI bleeding. They classify it as anatomical cause, and diverticulosis take the higher incidence. The anorectal causes, the vascular causes in a form of colitis, angioectasia, the inflammatory causes in a form of inflammatory bowel disease, infectious colitis, neoplastic causes, and others in a form of post-polypectomy, radiation, anesthesia, Dewey ulcer, small bowel in a form of Meckel diverticulum. Inflammatory bowel disease can be also in the small bowel, as we know that Crohn's disease, and wash out of the ileum in ulcerative colitis can present to the ileum also. Angioectasia can be in the large bowel and in the small bowel also. Neoplasm, and we said the ulcer, which is caused by non-steroid anti-inflammatory drug. Okay, about the presentation. How does lower GI bleeding present? And as we mentioned previously, presentation is dependent on the location, and so there is a diversity of the presentation. And among these are hematoschisia, which is a red blood per rectum, and melena also. So we have to keep in mind that lower GI bleeding, even lower GI bleeding per se, can present like as hematoschisia or as melena. This depends on the transient time and the severity of bleeding, and if there is time for the blood to be oxygenated and take its black color. So color doesn't specifically determine the location. It guides our location, but not a definitive guide for us for the location. This, if we are talking about acute bleeding, and it can also present, if it is chronic lower GI bleeding, it can present like iron deficiency anemia, or just we can detect it on positive fecal occult blood testing. We can also detect it. And I have included in this lecture the photo of how does fecal occult blood testing looks like, because I think it will play a crucial role in the next few years, not only in screening, in detecting lower GI bleeding, but also in the screening of cancer. As we said, approximately 15% of lower GI bleeding, it have upper GI bleeding sources, and the color we have mentioned, yes, that's correct, that melena most likely to be from the upper GI, but that doesn't mean that lower GI cannot present as melena, and we have to have a high suspicion of upper GI bleeding when melena present. Some classic words that in the history that give us a hint about the diagnosis. It's, for example, blood with mucus. This is, we are talking about inflammatory bowel disease, ulcerative colitis, and Crohn's disease or carcinoma. If we are talking about fresh blood as splashes in the pan, we are talking of piles. This is when the toilet is full of blood. And if we are talking about maroon colored stool, we are talking about Meckel diverticulum. If we are talking about red currant jelly in stool, it is a late presentation of intussusception. And if we are talking about bright red blood in stool, this is polyp. And here I remember when I started to talk about polyp that in some literature there is a classification that depends on the age, pediatric and adult causes of lower GI bleeding. Actually, it is the same causes what we already mentioned, but we have to keep in mind that rectal and anal polyps in children can cause bright red blood in stool. Polyps are common in children. Okay, let's move to the next slide, and it is the evaluation, how we will evaluate these patients. And regarding the evaluation, we always start by history taking and physical exam. I know that most of you hear history and physical exam as a routine job, but it is a very important and taking detail and training for taking proper surgical history is crucial and important. I know that some of you may do clerking for more than 10 patients per shift, and they take brief surgical history. And why I focused on that, because I will do a separate lecture for how to take proper history and clinical exam. Regarding the lower GI bleeding, we use actually the 10-step approach. It is 10 steps in which we follow to take all the information what we want. And about physical exam, this is actually follow what we called the CRESP protocol, or care of critically ill surgical patient, especially if the patient is hypodynamic or hemodynamically unstable. How I can take a history and a physical exam proper from a patient with a bleeding. I don't want to make you a little bit cloudy, but there will be a certain lecture about that. But what we want to know here at this topic, that we start by history, and this include first of all assessment of the stability, hemodynamic stability, and also taking a proper history about the amount of bleeding, frequency of bleeding, color, amount, frequency, and duration of bleeding, which can help us in localization of the bleeding itself. And if there is any abdominal symptoms such as constipation or a change in the bowel habit or weight loss, we have to ask. And if you are in an OSCE station in an exam and you didn't ask, or you make your top differential diagnosis a colon cancer, and you didn't ask in the history about weight loss, you will not take the full mark. Also, it's important, as we said, to have a high suspicious of colon cancer. How I can ask about colon cancer? It is the weight loss, it is the change in the bowel habit. Also, inflammatory bowel disease, how I can ask about them? It is mucus in the stool, if there is diarrhea or abdominal pain or extra intestinal manifestation like joint pain or ulcers in the skin, pigmentation in the skin, these which are associated with inflammatory bowel disease. If there is, I have to ask the patient about the anal condition, if there is any bulge from the anus, if we are talking about hemorrhoid, if there is a pain while defecation, or blood on the toilet paper, if we are talking about fissure. So this we have to take care about and ask about the coagulation profile in the coagulation profile, the antiplatelet usage, We have also to ask the patient about the family history, and this will guide us about the risk of malignancy. We have to ask the patient about the past surgical history, and this is crucially important, as for example, after colonoscopy, post-polypectomy bleeding is one of our differential also. And some vascular surgeries rarely may develop an aortoenteric fistula, which present as upper usually GI bleeding, but that doesn't prevent it to present as lower GI bleeding, but we have to ask if he had surgery in the past. Actually, we summarize what is written here. Okay, yes. Family history, we said about that. The medication also. Okay, about the non-steroidal anti-inflammatory medication and the management. Again, I have to repeat that the management of such patient, if he's hemodynamically unstable, this is follow the CRISPR protocol. And to simplify it, the CRISPR protocol is the ABC. I suppose that you have a background about the management of shock, the ABCD for management of critically ill surgical patient, but it's management, it's assessment and management. So I manage airway, and I assess it and I manage it. I may use oxygen supplement, or I may use endotracheal intubation. Also breathing, I have to assess it and manage it. Also circulation, I have to ensure that the blood pressure, the pulse oximetry. Also I have to, this is regarding the assessment, the management, I have to ensure 2 large bore cannulas and giving IV fluid. What's also? Okay, this is about how we are going to initially manage similar patient. And as initial assessment, also we have, if we are talking about lower GI bleeding, we have to rule upper GI bleeding, and this is simply by using the nasogastric tube and using some kind of lavage and lavage, and this will rule out upper GI source. This is as the initial management. We just started in the management of the patient. Also, under the word we just started, we have to rule out anal and proximal rectal disease, such as hemorrhoids and fissure, and this requires anoscopy, examination of the anus. PR also is crucial in the initial management. And actually, I summarize what's written here. This is the picture of nasogastric lavage as initial treatment for lower GI bleeding, and how we give some fluids, we give time for irrigation, and then we aspirate this fluid, and this how anoscopy or anoscope looks like, just to rule out more distal cause. And I have to mention that anal condition in a form of piles, hemorrhoids, or fissure, they are a common cause, that's correct, but they rarely can cause hemodynamic instability. So if there is hemodynamic instability, I have to think of more proximal cause. Risk stratification. And risk stratification, it's like asking yourself how much my patient status is dangerous or serious. And we will see this will guide us toward the morbidity, the mortality of the patient, how I can manage the patient, what is the appropriate radiological investigation, where I can manage the patient in the ward or in the as outpatient or in the intensive care unit. And the first question to ask yourself is what is the heart rate and what is the systolic blood pressure? And by dividing these two numbers, this will give us the shock index. And the shock index actually predict the stability of the patient. If it is above 1, that means the patient is unstable. And also predict the mortality rate. If you can see this picture, it also, once the shock index increase, it also increasing, there is increasing in the mortality rate. And also it can predict the need for blood transfusion. So the first two questions should be asked is are the heart rate and systolic blood pressure. Also, I have to mention that lower and upper GI bleeding have different risk stratification scores. I think some of you knows that there are ROCAL, I think, and Glasgow classification risk stratification for upper GI bleeding. These are for upper GI only. Unfortunately, the lower GI bleeding is not well studied like upper GI bleeding. What we have, the index shock and the Auckland scoring system. Yes, there are other scoring system, but they are not well popularized like Auckland scoring system. And Auckland scoring system also, if we see the variables that the Auckland scoring system, and to give you some hits of how important it is, if the Auckland scoring system is less than 8, we can manage the patient as outpatient. And these are the variables, and remembering these variables worth it, as also it's like remembering what should I ask the patient while I'm taking a history, or at what point should I concentrate. First of all, we see these variables. The first of all, the age of the patient, you see, as we can make a close zoom in, up, and hop. Okay, patient above 70 takes 2 points. Male patient take more than female, 1 point. Previous history of lower GI, previous admission to the hospital due to lower GI bleeding takes 1 point. Positive blood on digital rectal exam PR takes 1. Heart rate and systolic blood pressure, these are the shock index, also take from 0 to 3 and from 0 to 5. And hemoglobin concentration, these are less than 7, take 22, a large number. Actually, this is the classic Auckland scoring variables. There are a modified one in which they add the endoscopic finding, but I think for now this is enough. Okay, let's take a zoom out. These are, I told you that there are some other classification system. This is the Auckland for lower GI bleeding. This is the Auckland. There is bleed risk scoring system, and it's abbreviated by the word BLEED. It's not that important. No plaids, and I want to skip this part of. Actually, as I told you, less than 8. Auckland in the Auckland scoring system is can be managed as outpatient. And above 1, the shock index, if it's above 1, this means that the patient is unstable. Regarding the management, I assume that most of you have a background about shock. This is hemorrhage, this is shock, this is treating the patient, unstable surgical patient. We follow the ABC or as I told you, the CRISP protocol, which is the APC assessment and management. We assess the airway and we manage it. We assess B, breathing and manage it. We assess C, circulation and manage it. D, disability and neurological status, and we manage it. This is first of all. Also in the management, as an introduction for the management, we have to remember that about 80% of the lower GI bleeding resolve spontaneously. Please remember that some patients of lower GI bleeding can be managed as outpatient. Those who present as hemodynamically stable and just a feature of iron deficiency anemia can be managed as outpatient for elective colonoscopy, for example. Also, I told you about the APC protocol. I'm trying to summarize what's written. Also, we have from our general knowledge, we remember that blood transfusion have clear cut off in surgical patient, in patient who are suffering from shock. If the patient is healthy, we only give blood if the hemoglobin is less than 7 gram per deciliter, and if the patient we are talking here, by the way, 9 and 7, and if the patient have multiple comorbidities, so we give blood if it is less than 9. We increase the number a little bit. Also, from our general surgery knowledge, we know platelet transfusion only if the platelet is less than 50. Okay, what's else? Let's move to the next step. Okay, a special consideration about the reversal, how we reverse the anticoagulation, and when. There are no clear cutoff point, but some studies said that if the INR, international normalized ratio, is above 2.5, we have to reverse these agents. And some study found that there is a relation between the mortality and INR above 1.5, not between the INR 1.5 and bleeding or rebleeding, no, and the mortality. Okay, this is what I have already said just now. Special attention toward the consultation of the hematologist, especially if the patient have an active bleeding. Okay. Endoscopic evaluation. And regarding the endoscopic evaluation, and to make it easier for you, to explain for you why we are talking about endoscopic evaluation, keep it in mind that if the patient, as a general rule, if the patient is hemodynamically stable with moderate or minor intermittent bleeding, we go for endoscopic evaluation. Otherwise, if the patient is hemodynamically unstable with high shock index above 1 and or massive lower GI bleeding, we go for radiological investigations in a form of CT angiography and catheter-based angiography. Regarding the endoscopic evaluation, it's actually preferred as an initial step. We have to remember that the rule of upper GI endoscopy is important, as there is 15%, we have 15% of lower GI bleeding have an upper GI source. So we have to make clearance by upper endoscope. Also, the lower endoscope in a form of colonoscopy have a diagnostic and therapeutic properties. Also, if there are no ability to diagnose the patient, we can make tattooing for the bleeding site, so it guides us in the surgery. And per se, the colonoscopy, in especially in the lower GI bleeding, should be done by experienced gastroenterologist or colorectal surgeon, because we are expecting a field that is full of blood. So what we are going to do, we need to use a water jet. We need frequent irrigation of the colon. You can see this picture. Where is it? Here is the water jet. This is a water, and continuous irrigation need to visualize the mucosa. A question arises about the significance of bowel preparation. Yes, if it is amenable, if we can do bowel preparation, it's better than without bowel preparation. Also another question, when to do colonoscopy. There are different studies, but the American Society of colorectal surgeon found that early colonoscopy within the first 8 hours have advantage in early diagnosis and management, the early diagnosis and the definite management of the source of bleeding. So the general recommendation, do colonoscopy as soon as possible, and if you can, please do bowel preparation. While doing the colonoscopy, in case of lower GI bleeding, we need to intubate, we need to enter the ileum through the ileocecal valve in a retrograde manner. So we can rule blood in the ileum, which as a result can rule out small bowel bleeding. So you can see here the intubation of how the colonoscopist enter the ileum to see if there is bleeding. Here are the summary of these, what we already said. This is the table that summarizes what we said. The timing of colonoscopy. What is the best time to do colonoscopy? It is within the 24-hour, better within the first 8 hours. Bowel preparation, yes, it's recommended. How can I rule out small bowel source? By intubation the terminal ileum. If I cannot manage, I can just localize by tattooing the bleeding area. And how I can visualize, how I can see the mucosa. If it is full of blood, we use a water jet irrigation. In comparison to the CT angiography, as I said to you previously, it's used in a hemodynamically unstable, in more massive bleeding. It also needs the bleeding to be between 0.3 to 0.5 cc per minute to be detected. Less than that cannot be detected. Above that, the specificity and sensitivity will be decreased. The shock index above 1 And you can now recognize how important is the shock index is. And if there is, these are when can I do CT angiography? If I need 5 units of packed RBCs within the first hour. And if I did CT angio, please do three phase. These are the pre-contrast or non-contrast, the venous phase, and the arterial phase. The classic finding, it is the extravasation. I think there is a picture. I will show it to you. And in some cases, if there is a well-trained radiologist, he can see the clot. This is a subtle finding. Okay, let's move a little bit. These are general concepts about endoscopy. Now we are going to talk about the intervention. And about the endoscopic intervention, we already talked about the evaluation, we localize it, and the intervention. And we have to know that the complication rate or the adverse event is low during the endoscopic. It's less than 2. Okay. And we have here to remember that there are certain findings on endoscopic evaluation that can predict bleeding or rebleeding or recurrence, and these include visualization of active bleeding. And here I'm talking here actually endoscopy. This is include active bleeding and visible vessels and adherent clot. In another word, if I see on colonoscopy these finding adherent clot or visible vessel that is not bleeding or active bleeding, these are dangerous finding that should be managed because the risk of bleeding is high. And here you can see the clot, adherent clot in a case of diverticulum. There are different ways of how can I manage the bleeding, and these include clipping, cauterization, contact or non-contact thermal coagulation, the use of topical spray or powders, adrenaline, as a monotherapy, as a single therapy, or a combination therapy. But the study doesn't found superiority of a multiple therapy or combined therapy over single therapy. Okay, also in case if I need to inflate the colon a little bit, it's better to use the CO2 insufflation. Okay, there are some cases in which the endoscopic intervention have better results than other situation or other cases. In cases in which endoscopic intervention has a high benefit, these include diverticulosis, angiectasia or angiodysplasia, it's the same, and post-polypectomy bleed. These are, in another word, these are well managed during the lower endoscopy or colonoscopy, as opposed to the ischemic colitis or inflammatory bowel disease or colorectal neoplasm. These are not managed well by colonoscopy, but at least it can guide our surgical or multidisciplinary decision. If we are talking about diverticular disease, we can use clipping. We can put a clip on the bleeding vessel, or especially if we find a high risk of bleeding. And as we mentioned, the 3 main high risk are the bleeding, active bleeding, adherent clot, or visible vessel. And I know that some of you can talk about the forest classification, but again, forest classification are designed for upper GI bleeding. Forest classification, actually, these are the endoscopic findings that are associated with high risk of bleeding and rebleeding. Okay. As I told you that the diverticular disease are well managed by colonoscopy and no advantage in form of monotherapy or combined therapy. If there is active bleeding, we can use initially epinephrine to make vasoconstriction, then we follow it by a clip. You can see here the picture of how diverticular bleeding is controlled. Here are a translucent cap in which they evert the outpouching. They bring it up and put a clip over it. Can't be managed like this, yes. Let us make a little bit. Here is the bleeding. Here is the clip. Here it is. Okay. Okay. They talk also about banding. If you remember that banding is a a gold option for variceal bleeding. Some endoscopist, and this is actually depends on the endoscopist experience. Some will do banding on the left-sided lesion as a source of bleeding. Also, tattooing, here is the tattoo, how India ink used to localize the bleeding if needs, if we are planning to do re-intervention endoscopy again, or we are going to go for surgery. Also, angioectasia. Here I have also to mention about diverticular disease that the clip is preferred over thermal or coagulation. As in diverticulosis, the wall is thin, so clipping is the preferred monotherapy. In angioectasia, actually here written that the best way to manage angioectasia is by argon beam coagulation, and this is the argon beam coagulation, argon plasma coagulation. Angioectasia, angiodysplasia is the same. It is an arteriovenous malformation, and if you want to know how it's found in angiography, it's early filling dilated submucosal vein with slow emptying vein on the late phase. It's actually the angioectasia is more common in elderly and also more common in the right colon. It accounts for about 3% of the lower GI bleeding, and the risk of bleeding in angioectasia is associated with comorbidities and multiple angioectasias, and the use of anticoagulation and the use of antiplatelet therapy. As I said, endoscopic evaluation and treatment via thermal therapy is indicated, and argon plasma coagulation is the gold standard or the treatment of choice. Okay. Okay, here we also have to remember that there is a syndrome that is associated with angioectasia and aortic stenosis, and this is Heide syndrome. And in Heide syndrome, it's crucial to treat the aortic valve as it presents as severe aortic stenosis. Actually, In some literature, they says that it's a triad. Hyde syndrome is a triad. Angiectasia, with no explained correlation. We don't know why they present together. Aortic stenosis, angiectasia, and acquired coagulopathy. Volval brand, actually. Also, from the causes of bleeding that are well managed by colonoscopy is the post polypectomy bleeding, and treated with a high successful rate, about 95%. And there is a risk factor that are associated with rebleeding, and these include polyp size above than 2 centimeter, thick stalk, right-sided polyp, and also anticoagulation. And here you can see a picture where this is a post-polypectomy bleeding, and here we put a clip on it and everything went fine. Just as a general rule, if the choice is between using clips or energy-based method for stopping the bleeding, better to use clips, as clips can do less damage to the tissue. A special consideration to the radiation proctitis. Radiation proctitis can present as a lower GI bleeding, which have a different management. It's actually managed by radiotherapy, radiation proctitis is managed by thermic coagulation via NADIAG plus laser and topical formalin solution. This is the radiation proctitis. Okay, we talked about the endoscopy, colonoscopy, evaluation, and management. We are going now to talk about the radiological evaluation and management also. And as I told, I would like to repeat, please remember, if the patient is stable, shock index less than 1, moderate or mild lower GI bleeding, we go for colonoscopy as a general rule. But if the patient is unstable, shock index above 1, needs blood products more than 5 to 6 per day, we go for radiological evaluation and management, and we will see in the next few minutes. And about the radiological evaluation, we are mainly talking about two modalities: the CT angiography and the catheter-based angiography. About the CT angiography, actually it is diagnostic. As we mentioned above, we use it in patients who are usually hemodynamically unstable with shock index above 1, and this is associated that with the finding on the CT. If the index is above 1, it's more likely to find extravasation, have advantages over the bowel over the colonoscopy, that it doesn't need bowel preparation. What we find, we said that there are two main findings. These are extravasation, as seen in this picture. You can see that the contrast extravasation in the upper rectum. Also, we said that we can detect the clot. Actually, we use 3 phase, and these 3 phase are non-contrast venous anti-arterial, and this increases the sensitivity and the specificity of the bleeding. We said that the bleeding should be above than 3 milliliter per minute, or from 3 to 5, and some says less than 3 if we use the triple phase CT angio. Actually, if we found a negative CT angio, we did a CT angio and the patient was stable, this means that no intervention needed, there are no bleeding. In a case of their patient who confirms that have GI bleeding, but we didn't found a CT angio finding, we can use what we call the provocative CT angio, and this include adding okay, I'm sorry, my wife just called me and I forget to put the phone on offline mode actually. What's else regarding the CT angio? We said that one of the advantage that it doesn't need bowel preparation, but another disadvantage appear in a form of contrast nephropathy. We use contrast, so we have to pay attention. This is regarding the CTA, CT angio. Other modality is the catheter-based angiography. And to increase our imagination, this is the catheter-based angiography, and it is the only radiological way that can diagnose and can treat the bleeding. You can see here the bleeding like a dot. In the CT and catheter-based angiography. Actually, some literature use this modality as a second step after CT angio. It can detect bleeding in a lower layer. Any bleeding above than 0.5 milliliter per minute can be detected. Actually, we can have positive CT angio and we proceed to angiography, but we found a negative angiogram, and in this case we use what we also mentioned before, the provocative angiography. In another word, I did CT angio, there is a bleeding, I proceed to angiography to embolize, to treat this source, but I didn't find anything. What I do, I dilate, I give some agent that induce bleeding to detect the site, and these include, for example, nitroglycerin, heparin, urokinase, and tissue plasminogen activator. But this should be done in a good center. As I said, this should be done in an experienced center. If we are talking about super selective embolization, this is directed toward the artery that is less than 1 millimeter in diameter. What we can use as an agent, we can use microcoils, we can use gelatines, glue, polyvinyl, different agent we can use for embolization. Okay. Even in the case we doesn't control the bleeding, this can help us to guide us in the surgical resection. One of the complications that are well recognized, rare and self-limited, these are colitis, ischemic colitis. Of course, we are going to do embolization of the vessel. We are going to make a cut off in the bleeding. So colitis can present in a form of abdominal pain and rise in the lactic acid, but actually it's a self-limiting, and the major ischemic complication is less than 3%. Okay, these are the radiological investigation. We are moving to the nuclear medicine or nuclear investigation. And if we are talking about nuclear medicine, we are talking about two modalities. These are the sulfur colloid and RBC tagged or technetium labeled RBC. And they can detect bleeding that are in lesser amount than angiography, but it takes longer time to in scanning. Also as a general rule, and I know that some of you are thinking of an algorithm for the management of the lower GI bleeding. We will see it later, but as a general rule, we use a nuclear medicine or these two modalities if we are going, if we did colonoscopy. And when we did colonoscopy, by the way, we said on a minor, on a mild or moderate bleeding with a shock index that is less than 1, so the patient is stable, and we didn't localize the bleeding on colonoscopy, so we moved to nuclear medicine or these two modalities. The difference between the RBC tagged and sulfur colloid, that RBC tagged, we take RBCs from the patient, we inject our nuclear material or the material which will give us the image, and we re-inject this blood on the patient. And to be fully exerted from the body, it takes about 24 hours, 1 day. So this gives it advantage that rescanning of the patient is possible, especially if the initial imaging is negative. Also give us that the patient need to be stable. We are going to scan the patient for about 24 hours. In contrast, the sulfur colloid, it's an external material that we inject in the body, so it doesn't need preparation, but it takes less time to be exerted. It takes, I think, less than 3 hours or 4 hours to be exerted. So we have less period in the scanning. As you see, it can detect bleeding up to 0.04 milliliter per minute. It can detect it, but it cannot localize it well. Of course, it lacks the therapeutic capacity or capability. The therapeutic capability. We said that the patient's stability is required. We said that radiolabeled RBCs takes up to 24 hours in scanning. Actually, this nuclear medicine method has been replaced by the radiological method, the CTA and the catheter-based angiography. Okay, this about the nuclear medicine. This is a picture of how nuclear study for GI bleeding looks like. Here, GI bleeding, I don't know. I don't think that we, our surgeon, are interested and similar cases. So, recurrent lower GI bleeding. We are now treating with a patient who present with bleeding that have been already stopped. And recurrent lower GI bleeding can be classified as early and late, early before the hospital discharge and late after the hospital discharge. Early usually much more common if the patient if the patient still in hospital. More common, it's about 22%. Nothing specific about recurrent lower GI bleeding. We need to, if we did colonoscopy or angiography, we need to repeat them. Special consideration about the intubation of the ileum. We need to assess the small bowel if there is a small bowel bleeding. The risk of lower GI of recurrent lower GI bleeding, or what are the parameters associated with high risk of lower GI bleeding. These include anticoagulation, multiple comorbidities, malignancy, non-aspirin antiplatelets agents, clopidogrel, dual antiplatelet therapy, age above 65, and if the cause was, for example, diverticulosis, which is associated with massive bleeding. These are associated more with recurrent lower GI bleeding. About the prevention of recurrent bleeding, it's written that please avoid non-steroidal anti-inflammatory drug and no need for regular aspirin or routine aspirin for prevention of cardiovascular event, especially in these cases. We say that if there is recurrent lower GI bleeding, repeat the colonoscopy, repeat the upper endoscopy. If it's not found, even repeat the CT angio. Okay. Of course, we are going to talk about, if we are just talking about recurrent GI bleeding, there is a problem that if we didn't find the location, or we are facing a problem if we didn't find the location, actually we are going to a blind end in a form of surgical resection, blind resection. But this will be the last resort, the last solution for us, in which we didn't determine any bleeding. The CT angio, the upper endoscopy, the colonoscopy, the evaluation of the small bowel didn't reveal any bleeding. We can proceed for surgical resection. We will talk about it in the next few minutes. Small bowel GI bleeding. It's a little bit difficult. If you remember at the beginning of our lecture, I said that obscure GI bleeding, which is found, which we cannot find it on the colonoscopy or even the radiological investigation. There is clinical bleeding, but we cannot find the location. Actually, the source is small bowel, and sometimes obscure GI bleeding, call it suspected small bowel bleed. And if we are talking about the causes of small bowel bleeding, these are inflammatory bowel disease. We said that inflammatory bowel disease can present as a small bowel in a form of ulcerative colitis, as a pachycephalitis, or Crohn's disease, which can affect all the GI tract. It can be angiectasia, it can be neoplasm, AIDS-induced ulcer, Dewey lesion. This can be a cause of small bowel bleeding. Again, to confirm the information, if we are talking about small bowel bleeding, we are mostly talking about obscure bleeding. This is the bleeding that we didn't localize on our initial colonoscopy or CT angiography. Sometimes the obscure GI bleeding, we call it suspected small bowel GI. We cannot say that this is a small bowel bleeding unless we did a second look endoscopy, in which we mandatory have to examine and intubate the area. Okay. Of the modalities that we can investigate the small bowel is the enteroscopy. The enteroscopy have two modalities. These are single balloon and double balloon. We will see it later, and there are different mechanisms. One of them are push endoscopy. There are two main modalities in which we can investigate the small bowel. These are, in addition to the colonoscopy, if we intubate the ileum, these are the capsule enteroscopy and the push and the balloon endoscopy. Here you can see these two findings. These are the capsule. The patient swallow the capsule and he is wearing a detector, and actually it visualizes the mucosa. Actually, what I want to add also here, that small bowel bleeding or obscure bleeding usually in a stable patient, in the background of a stable patient, it's not massive. So we have time to study it with capsule enteroscopy. Here a diagram, I found it in one of my literatures, and it explains how we should manage. Let us make a zoom in how we can manage obscure gastrointestinal bleeding. First of all, they say, please rule out upper and lower bleeding. We said that in a case of obscure bleeding, we have to do colonoscopy and upper endoscopy twice in a form of colonoscopy and endoscopy. Here they mentioned that if it is a minor intermittent bleeding, so we can do what we already said, and actually it is a minor and intermittent bleeding, by the way. We can do the enteroscopy and capsule endoscopy. If it is positive, please do the appropriate treatment in a form of cauterization or resection. If it's negative, please repeat the colonoscopy and the endoscopy. If it is minor bleeding, and if it is a major bleeding and persistent, this depends on the stability of the patient. If the patient is unstable, the patient is unstable, we cannot detect the bleeding on the endoscopy, on the colonoscopy, on the CT angio, so we have no solution if the patient is unstable except to go for surgery. And if the patient is stable, there are major bleeding, and the patient is stable, we can do RBC tagged scan. Okay. Okay. Enteroscopy, we had talked about the enteroscopy. It is form of endoscopic study of the small bowel. It needs a trained colonoscopist or GI specialist. It goes more far in the small bowel. Nothing to say you can specific about it. You can see there are two modalities: single balloon. Here you can see single balloon enteroscopy and double balloon enteroscopy, and what's written above that there are no difference between each. It depends on the endoscopist experience, the usage of both. Okay, now we are going to talk about the surgery, and I think it's not justice, it's not fair. You see how much the lecture is, and the surgery, the rule of surgery is like this. And actually, in case of lower GI bleeding, keep the surgeon away. It's better for. And the rule of surgery, actually, it's like the final solution. We reach a blind end. We cannot, actually, the patient should be unstable. In some literature, you can find that he or she needs transfusion more than 10 units per 24 units of blood per 24 hours. We repeated the upper endoscopy, the lower endoscopy. The patient is unstable, so no rule for radiological nuclear investigation or capsule therapy. What also we have, if we are going to resection, actually, please do your best to do oncological resection. Of course, the radiological investigation which fails to stop or to treat the bleeding can help the surgeon to at least localize the bleeding. Okay, we are going to talk more about the rule of surgery, but this what is written at this page. Non-localized lower GI bleeding also. Here the surgeon can appear with his or her knife. Non-localized bleeding. And non-localized lower GI bleeding doesn't mean obscure or small bowel bleeding. We already investigate the small bowel, we investigate the upper GI, we investigate the lower GI, but we didn't find a location. So our solution is a blind subtotal colectomy. And by the way, recurrence of rebleeding after a blind subtotal colectomy is about 4%. So it's like the patient is asking you to leave this planet. Actually, we said that non-localized bleeding, these are bleeding that have no colonic bleeding, anoscopy is negative, terminal ileum is negative, even everything is negative, so we have no rule except that. If we are going to the surgery, actually this depends on the patient stability, but you are already in the abdomen of the patient, so run out the GI system. You can feel the GI system. If there is any mass, you can do clamping to check if you can control the bleeding in one segment or in one of the arteries that are seen. and this is not my opinion, this is what's written on the lecture. Nothing I said, by the way, was from my own imagination. This is what's written on the lecture. We can do more than examination of the GI system. Also, we can do colonoscopy or endoscopy or enteroscopy via through an enterotomy. We open the small bowel and we insert an endoscope and we visualize. But as I said, this depends on the patient stability. Also, providing a stoma for the patient or resection and anastomosis depend on the stability. If we have time, please do loop ileostomy, and this can help you in determining post-op if the bleeding is proximal to the site of your resection. What else also? We said that the stoma is preferred and depend on the patient stability. Of course, doing a stoma is more rapid, but in a case of loop ileostomy, it can also guide us on finding the proximal causes. Okay, these are the algorithm that I mentioned before, that some of you are waiting until we reach the algorithm, but nothing more than added more than what we said. These are the different three algorithms. One of these are from appreciated literature. If you want, you can ask me. I can send it to you. I can send for you the PDF. But what's written in this algorithm? What we already said. If this depends on the patient stability and the shock index, if the patient is stable with mild to moderate bleeding, go for colonoscopy. If the patient is unstable, go for CT angio and angiography. If the colonoscopy is negative and the patient is stable, you can scan the patient with nuclear medicine. If the patient is stable and there is a suspected small bowel bleeding, you can do enteroscopy or capsule enteroscopy, capsule endoscopy. This is what's in this algorithm actually. And finally, if no solution, if we cannot localize, we can proceed for blind resection. Actually, the last algorithm, I see it more dynamic, more information rich. You can see that we started by NG tube. Before that we started with resuscitation, NG tube, and on the other side anoscopy and rectal exam. These are the main important. And here, if it is massive bleeding, we go for angiography. If it is intermittent or moderate bleeding, we go for colonoscopy. Thank you, dear colleagues. We reached the end of our lecture. The sources as written here, I used different sources to build a general imagination of the lower GI bleeding. As I mentioned before, it's not well studied like compared to the upper GI bleeding. I hope that I delivered as much of the information I have for you. I am Dr. Jihad Musbah Al-Jarrah, Jordanian Surgical Board, member of the Real Medical Services, and a general specialist and colorectal fellow in the Real Medical Services. This is my number. I'm happy if you contact me regarding the improvement of the content, and if you need the PDF, I'm happy to send it for you. Thank you. Bye bye. Good night.